All right, so the objectives of this hepatitis B presentation is really to do state of the art and talk about epidemiology, virology. Natural history of hepatitis B is very important, especially relevant to and relative to our research studies. Recommendations about screening and vaccination for hepatitis B. It doesn't say vaccination on here, but that's part of the management of hepatitis B. We'll give you some fake news about hepatitis B, things we want to correct, and then current treatment options for active disease patients who fit treatment criteria. I just like starting out with this slide because the hepatitis B virus is related to viruses that are in many other animals. And you can see what's a super hot topic right now is bats. And bats definitely carry a version of hepatitis B. The ones that are closer to us are in chimps. Chimp research has stopped, but there are some other primate research that takes place, including in macaques and a few other animals that are similar to the macaques. One second. Clear my throat. So this is a virus that's been in humans probably for about 40,000 years. Some people, like myself, believe it jumped into humans in East Africa, the Rift Valley, as people were living in Africa and then moved around the world. The virus got moved with them. There's other people that think that it jumped from animals to humans at different places and different times. And that may explain some of the genetic heterogeneity of the virus in humans today. There are at least 11 genotypes going from genotype A all the way out to J. And genotype A, B, C, and D are by far the most common and really what's relevant to clinical practice today. I have seen a few genotypes E from West Africa. Genotype G, I've also seen and published on genotype G. Actually, we wrote a paper on that from some patients in San Francisco. But genotype A also has two different subtypes. A1 is Africa, A2 is Europe. But we're not clinically genotyping patients in practice today, but anybody who's doing clinical research will have genotype information on their patients, as well as a few other things, which I'll talk about shortly. Historically, genotyping wasn't just a geographic issue, but genotype C was more related to higher risk of cirrhosis and liver cancer, as example. Genotype A2, the type in Europe, responded really beautifully to interferon, which we don't use anymore, but very nice historical perspective. So this is the byline that's really important that gets everybody's attention. I'm going to be speaking to a couple hundred people tomorrow at the Filipino, community society in San Diego. And I'm going to be talking about viral hepatitis, especially hepatitis B, because it infects or affects a huge number of Filipinos and other Asia-Pacific Islander immigrants. But when you start out that 2 people are dying from hepatitis B every minute worldwide, that gets people's attention. And you say that the most common region of the world where you find hepatitis B is Asia and the Asia-Pacific region. And third behind those 2 regions are going to be sub-Saharan Africa. We think right now in the world, there's 296 million people. And in the US, 2.4 million people. 20 to 30% are going to get cirrhosis or cancer. And of course, those are the pathways that this usually leads to patients dying. So US, I just mentioned 2.4 million. Obviously, Asia, you've got the biggest concentrations. There's 90 million people in China. So this is a big market. This relates back to clinical research. Pharmaceutical companies do go to rare diseases for specific reasons, and they go to common diseases. In hepatitis B, eventually we're going to want to treat every single patient who's infected, but that's not happening quite yet because of cost and risk benefit of our medicines. But that's the path we're on in the next decade. This just gives you a little bit more of a focus on the Asia region. And I've been in many of these countries that are here: Pakistan, India, Thailand, Vietnam, Indonesia, Malaysia, Philippines, Korea, Taiwan, Japan, obviously China. Been in all those countries and probably go to more in the near future. Yeah, lots to happen here. I've actually been in Iran, haven't been in Iraq yet. I've been in Saudi Arabia and all the Emirates as well. A lot of viral hepatitis in all those places, hepatitis B and C. Now, the good news is this left graph, you see all those little lines going down? That's because of vaccination. We started major vaccine policies 20 to 30 years ago, and they're being implemented in most countries at a very, very high level. But that's not the way to end a pandemic of hepatitis B. You have to come up with treatments for the people that you don't want to die of the disease. But prevention is critical, and this is getting better all of the time. It's just really fantastic news. This vaccine making a difference is just more graphs on vaccine, and you see shifts 1990 upper left corner, and then down in 2015, there's a lot less red, moving to a lot more yellow. China changed dramatically from about 10% down to about 4%. So there's two types of hepatitis B. What you're going to see in an Asian population, which relates to our clinical research program, it's going to be patients from East Asia, Southeast Asia, who acquired their hepatitis B at birth or in early childhood. These tend to be patients who have a lot of inactive disease. The specific clinical trial that we're working on right now is inactive disease. These are people with normal liver enzymes. Liver enzymes are how we define inactive disease, as well as by liver biopsy in some patients. But the viral load can be high, but we also are defining patients' level of activity by what their surface antigen level is. And I'll talk a lot more about that surface antigen shortly. North America tends to be adult acquired, a lot more active disease, higher ALT, but also higher chance of clearing the infection. Because when you clear the infection, your risk for liver failure and liver cancer goes down. Adult acquired hepatitis B has a generally better prognosis than if you acquire this as an infant. So this walks you through what happens with patients. You have these black and red boxes at the top, chronic hepatitis versus inactive disease. That's defined again by liver enzymes, AST and ALT. Healthy AST and healthy ALT, indicating inactive disease in women would be an ALT less than 25, and in men an ALT less than 35. There's other forms of defining activity, how high or how low the viral load is, the hepatitis B DNA test, and we'll get into that in quite a bit more detail shortly. It's this active disease with inflammation, high enzymes that has a much higher risk of leading to cirrhosis and to liver cancer. But inactive disease can lead to definitely cancer. Rarely does it go to cirrhosis unless it's oscillating between inactive disease and active disease through this reactivation step. There's something on here called occult hepatitis B. I'm not going to go into great detail about that today. That's a kind of a hidden disease that we're learning a lot about. You can find hepatitis B through other special testing. But every time we see a hepatitis B patient, we motivate them by saying, you're a man, you have 30 to 40% lifetime risk of cirrhosis or cancer. Women, 15 to 20% lifetime risk. Men have worse outcomes, we think probably because of hormonal differences with testosterone versus estrogen. It does not appear to be related to alcohol, difference in consumption, or say fatty liver. There's something that's gender related here. So this is an extremely important slide. When we are working up hepatitis B, every patient gets this triple panel. I just gave a talk on this triple panel to Quest 2 days ago, which we recorded. And once that gets posted, I'll share that out with the team. I would advise you listen to that presentation. It's about 40 minutes long, and it goes into a very deep level about these tests. Quest, at my request, so to speak, just rolled out this new triple panel that's a order set that people can order because people are ordering all the wrong tests in the past. And I'll talk about those wrong tests shortly. So surface antigen, if it's positive, it equals infection. It's just very, very clear. And those people were also testing after their surface antigen is identified. We're testing for delta hepatitis with an antibody test. I'm not going to talk much about delta today, but that may come up later. The second test is something called core antibody. Core antibody equals exposure. This is an incurable virus. So if you've been exposed, you're carrying that virus in your body as a patient the rest of your life. And that means that there's some hidden virus in people who are core positive, but surface antigen negative. I said surface antigen equals infection. So if surface antigen is negative, you might come up with the idea that that means no infection. But the core test indicates that there is a very low level of persistent disease in the liver if it's core alone or core plus surface. These core patients, core positive, don't need vaccine, and we need to educate them about risk for reactivation. Antibody to surface anti-HBs means immunity if core is negative. If anti-HBs is positive and core is positive, we call that immune control. So if someone's been vaccinated, they're going to be surface antibody positive only. So as you're going through charts, and I talked to Talia, Claire, and Alexander, maybe it was Alexander and Claire this week about the database, people sometimes are diagnosed with hepatitis B, and it's just because they're core positive or core plus surface because of confusion about interpreting these tests. So we have to be cautious about seeing in somebody's chart that they have hepatitis B unless we have current documentation, meaning in the last 1 or 2 years, that the surface antigen test is positive. We do tell our patients this is incurable. There's no natural immunity. That's a term a lot of specialists, really smart people use that term, natural immunity, for the last 30 years, and it's wrong. Because you can't be naturally immune to something that's an incurable disease that persists in the body. That's why we switched to this term called immune control if somebody's core positive and surface antibody positive. So this is a huge amount of information on one slide. This constantly confuses people until they just keep looking at this and sort of repeating what this looks like. And sometimes looking at this in the form of grids, and then also going through charts and thinking about their patients and thinking about the virus. Now it gets complicated. So in somebody who's surface antigen positive, I, as a hepatologist, do all of these tests, or almost all these tests. I'd say actually everything on here I do, yes. And this is where hepatitis B is pretty complicated because there's all these guidelines, there's different rules for different tests that are positive or negative or different levels. But I'm going to jump to a couple of important things on here. You'll see that there's an ultrasound Doppler on the spleen and portal vein size. So the message here, in combination with a few other tests that are on this slide, is we want to stage everybody's liver disease because every research study wants to have patients at certain stages. And specific to our current project, they want patients with minimal evidence of fibrosis, minimal evidence of liver damage. And it's a special population that we're looking at with low activity, low liver damage. And you would say, well, why treat those people? They're at the lowest risk or low risk for cirrhosis or cancer. Shouldn't we be focusing on other patients? Well, these patients still have a risk for developing cancer, specifically the lower risk for developing cirrhosis, but they can all reactivate in the future and then progress as they reactivate. Also, with hepatitis B, there's a huge stigma associated with being surface antigen positive. And that stigma impacts patients' lives immensely. And every patient who has hepatitis B who's surface antigen positive wants treatment and wants that surface antigen to go negative. So our study is extremely relevant to patients today although most companies have ignored this group of patients, one, because they think they have a lower chance of responding, and two, because there's this theory that they're not going to benefit from therapy as much. But this lack of benefit has ignored the patients in terms of what they're thinking and feeling, because stigma is a huge impact on family, marriage, interactions with people at work, in the community, isolation, self-isolation, being ostracized from a family setting or a community. And in the Asian community, having any medical illness is a sign of weakness. So especially in the Asia Pacific population, people don't like to admit they have diseases, don't want to tell their family because of that weakness, that stigma, maybe the inability to have work or normal family relationships. Always check for hepatitis A. We've mentioned Delta, you need an HIV test in these patients' charts. Hepatitis C, of course, chemistry panel, enzymes, CBC, platelet count. And on a lot of our conference calls, we're talking about different hacks to think about looking at shortcuts that are accurate and helpful. And one of those shortcuts is looking at the CBC and looking at the platelet count. If you have a liver disease patient, whether it's NASH, viral hepatitis, or others, and if the platelet count is under 150,000, it's extremely likely they have advanced fibrosis. And if it's under 100,000, the platelet count, it's very likely they have cirrhosis. So super fast, you can just start filtering patients in or out of different clinical status that way. We're going to measure or look for fatty liver in all of our hepatitis B patients. The best way to do that is with a Fibroscan, and that CAP score on the Fibroscan tells you how much fat's in the liver. So that's useful, of course, for NASH studies, but it's useful for other studies or other patient assessments also. I think those are the relevant things on here. There's a lot more I could talk about on this slide, but we're going to keep moving. So part 3, also take an alcohol history. I'll check their kidneys. We look at bone health through a DEXA scan. We have other ways to stage the liver through what's called an APRI or FIB4 score. These are online calculators, family testing. We have some other tests that are blood tests that are listed here, FibroSure, FibroTest, so liver fast, and help us stage the liver disease as well. So back to that slide that had the 3 key tests on it. Now I mentioned a grid. And this is a grid that puts these 5 profiles together, different combinations of these tests and what they mean. So I'm not going to walk through this grid because I could spend 20 minutes just walking through this grid, which is really an expansion of that other slide. But this is a nice table to print out just to have at your workbench or near your charts, and just tells you and captures what I think about a patient who's sitting in front of me with a given profile 1 through 5. So this is very valuable to look at, study, have on hand, and really reiterates what I talked about on the other slide, but just in a little bit more detail. This is really important. So look at that far left box. It's called chronic infection, high DNA level, normal ALT, minimal fibrosis. That sounds like our research study, right? So this is this earlier phase, but you can find this phase in many different age groups. We tend to talk about this being a younger age, sort of birth to 20 or birth to 25. Then the immune system activates in that 3rd decade of life, and you develop, instead of chronic infection, which means normal ALT, chronic hepatitis, which indicates an elevated ALT. Also, HBV DNA level can be quite high. These people are at higher risk of progression, but they also might clear virus from the blood. They might clear the DNA. They might clear the E antigen, which is another protein the virus makes. And they can change from minimal damage to active inflammation, active fibrosis. Then this E antigen that the virus is making, when it's a wild type or natural type infection, can change because the virus mutates and stops making e antigen through some specific mutations called core and pre-core mutations. E antigen goes negative, but they still have chronic inflammation, elevated DNA levels in the blood, and they also are at risk of progression. And they're a little harder to treat, a little less likely to respond to oral medications, less likely to respond to immune modifying medications like our research study. Then they go into this immune control. I used that word a little bit earlier. There's two types of immune control. This is this chronic infection where the DNA level has gone negative or very low. The antigen has gone negative. S antigen levels are falling. ALT is normal. And those people might clear the virus from their blood. And then you go to this S antigen, which is the far right, the fifth stage, where S antigen is cleared, but they still have some virus in their liver and they have a little bit of virus in their blood also. So I'm going to stop here and just see if people have questions, because we've covered a huge amount of ground in the last 25 minutes or so, but this is really, really good.
This is really great information. I have questions, but I don't want to, who else might have questions? Anyone from the research team?
I have questions also. I think my question is maybe a little bit common sense. So sorry, Dr. Gish, if this is, but so reactive and positive, whenever we have a patient that has a HBsAg reactive in the results, does that mean the patient, just talking about altimmune, is that the same as the positive value?
Yeah, I'm sorry that that's confusing, but that's the way it is. I'm glad you brought that up. Yeah, reactive equals positive. And then often reactive will go to, I'm trying to think of the other word that they use, confirmed. So all of the labs will do a first surface antigen, then they do a second test to make sure that it's confirmed. And that those are, the two tests are slightly different because there's occasional false positive on the first test. And that's built into this new Quest panel that's coming out, which I thought was great.
Yeah, definitely. Yes. And then last time we met, we talked about the values. So you suggested anyone under 200 we should test because the protocol needs it to be more than 1, but less than 100. So I came up with the person that had labs on June, but the values are in the 600s. Do you think that will lower into the 100 range without, like, within a year or so?
1% chance.
Okay, so no, it's not worth it to screen the patient because—
That's correct.
Okay. Thank you.
Great questions.
And, that's all I have right now because you covered most of the things that I wanted to ask you about in the beginning. Thank you.
Thanks. Other
Nguyen, go ahead, please.
Yeah, I would like to have a question about the vaccine. If someone take the vaccine and they have antibody, so I would like to ask you how long they will repeat the vaccine.
So the vaccines that we have today, and I'm going to say the vaccines we've had for the last 20 to 30 years, appear to provide immunity lifelong, and we don't need to recheck the antibody, and they don't need boosting. So if you get the 3 vaccines for Merck and GSK, 3 doses, you get the 2 doses of the Dynavax vaccine called Hepatitis B, you're protected lifelong. You don't get boosters, you don't check titers, you don't check antibody, you give the 3 doses, you say you're protected, goodbye.
So, you know, if they have antibody, they don't need to booster, I don't need to check the antibody later.
We don't even check the antibody first. So people get 3 doses or 2 doses, no more testing. Although you are telling me when that people do test, which is true. And what do you do with that information? You go, oh, there's an antibody. Great, we're done. Yeah. Then you also say there's no antibody. And then you say, great, we're done. That's why we don't check the antibody. Because even if you get the vaccine and you don't develop antibody, you're still protected because these vaccines affect B cells and T cells. And the T cells are part of that immune protection.
Okay, thank you. The second question I would like to ask you, can you tell me the difference between elastography and Phytoscan? Because sometimes, on the top study, I saw some doctor order, sometimes they order elastography, and sometimes they order Phytoscan on the same basin. So, I don't know, that is the main difference between elastography and Phytoscan. And also on the top study, they only require elastography, but they don't require Phytoscan for inclusion criteria. So, can you tell me the main difference?
Okay, so Fibroscan is a brand name of a machine made by a company called EchoSense, and that Fibroscan machine measures liver stiffness, elastography, through a very specific device. And we can talk about this at maybe one of our other educational conferences. So it's a brand name and it measures elastography, but the word elastography is a general term of measuring liver stiffness. And there's at least 5 techniques or 6 techniques to measure liver stiffness. And one of those is Fibroscan and Siemens, GE, the company called Sonic Insights, there's magnetic resonance. They all have different methods of measuring elastography, but all of them are based on pushing a sound wave through the liver and then measuring the speed of the sound wave as it goes into the liver and bounces back to a sensor. The elastography order might point the patient to a Fibroscan, but there's another machine that's inside San Jose GI that's made by a company called Explorer. And that is actually the company Supersonic. The machine is called the Explorer, that measures sound waves through something called 2D shear wave, which is slightly different. And they get that measured when they do a regular ultrasound. They can also measure the liver stiffness using that device. So I would prefer that everybody in the group just ordered a Fibroscan, because the Fibroscan right now has very complete data, not just on liver stiffness, but also on CAP, C-A-P, which is a measurement of liver fat in that liver.
Yeah, thank you. But the reason I ask you is that, because on PAP study, yeah, they on the inclusion criteria, they require elastography, but when I recruit the basin, the basin doesn't have elastography, but they have a Phytoscan. Can I use it to do the recruit basin or not?
The answer is yes, because Fibroscan is elastography.
Oh, so I can use it right now because I have many basin recruit the top basin, but on based on the protocol, they require elasto, but sometimes they have a Phytoscan. So right now I can use the Phytoscan to recruit the basin.
Absolutely. Fibroscan is elastography. If you see the word elastography, you plug in the Fibroscan value, that kPa value. It's most commonly expressed as kPa, which is kilopascals, but you also might see it in meters per second, which then needs to be converted either to kilopascals or to an F score. But EchoSense, Fibroscan is elastography.
Okay, I see. So yeah, So,
Yeah,
you know,
Nguyen,
okay.
the way the Dr. Trin and the team wrote that protocol, because it's an investigator-initiated trial, was they left the elastography as a general term so that either machine, either method of capturing it, whether it's Fibroscan or through one of the other machine Dr. Gish mentioned, would be acceptable.
Okay, okay, thank you. I see.
Yep.
Thank you. Yeah.
Great question. Kang or Ni, any questions?
I don't have any. Thank you. I think Dr. Gish covered a lot of that we needed. Thank you.
Yeah, what I've covered today is really has been built on, being in this space for 30 years and hearing all these different questions that people ask, and then how do you present this information to answer those questions that are sitting in everybody's mind every day. So I've been taught this, what you're hearing today is my colleagues, my patients, and the people I work with in the community have taught me how to get this information and be, quite clear about it and be very current and address a few of the controversies that are there. So I'm glad this has been complete. I have a lot more to do, but I really wanted to stop here because this is super foundation for research studies.
I'm not sure what else we have for the next, if you had other items, just to that point, Dr. Gish, that you wanted to review. I have some more questions and maybe other members of the team do as well. Should we keep going?
Do your questions and then I'll fill in the last part of the time with the rest of the talk, because I'll share these slides with everybody. But I really wanted to focus on the clinical trial.
Yeah. Okay, I'll ask a few. Oh, sorry, was I talking over someone?
Me, but it's okay.
Go ahead.
I can
No,
ask
Ollie,
for
please.
you.
No, Ollie, please.
Okay,
please.
so per the ultimate exclusion number 2, it says positive, like it excludes patients with positive hepatitis B E antigen. So if a patient that I'm looking at has reactive hepatitis B surface antigen, is that the same thing?
So E antigen is made by the virus and during its active, this chronic hepatitis, immune clearance, chronic infection. It's a protein that's very different than the surface antigen. E antigen is related to what's called a core antigen that has to do with how the virus is packaged. The E antigen indicates a more natural infection, less mutations, an earlier form of the disease, a more active form of the disease. So if you see E antigen negative, which is what's in the Altimmune study, right? That means a less active disease, a later form of the disease, or just a low activity level. Surface antigen is a completely different protein that's providing the total outer coat of the virus. As the virus gets packaged, it's basically put into, I call it, into a room in a house, and then you build another house around the room in the house. So you've got this double protection layer. The surface antigen also is very important for moving the virus into new liver cells, because it's the place where it attaches to the liver cell with the surface antigen, and it gets taken up into the next liver cell and infects that. So E antigen has much more to do with the phase of the disease. Surface antigen has to do with, are they actively infected or not? We want that S antigen to clear. That's why this research study is picking patients with low S antigen, because they're more likely to respond and clear virus with this immune intervention.
This is super helpful. I was confused between the two.
That's very important.
So to further on that point about E antigen, Dr. Gish, E antigen, is it true? Is it a true statement that E antigen is it's rare that we would have data in the EMR on E antigen? It doesn't feel like that is something that's routinely tested in clinical practice, and that is a study specific test. Is that a correct statement? It
should be in every patient's chart. And if it's not, it needs to be ordered. We need to know the E antigen status on every hepatitis B patient.
Really? Do we have, is that common, Ale? Are you seeing that in the charts? E antigen status?
Not in all.
In some though?
Yeah, in some.
But Ali, is some 15% or 75%?
That I'm seeing it in, no, like a low percentage.
All right, so that's a problem for the group that I can talk to Hui about.
Okay.
The way the protocol is written is that we will test for E antigen as a study test at screening. So you know, if we have an unknown E antigen status going into the screening visit, it's not an issue. It's just that we may see many screen fails that we could otherwise rule out if we had the data. But it is a test that will be ordered at screening, whether we have the data or not.
The good news for you all, if you pick patients with low liver enzymes, older age, it's very likely they're going to be E negative.
Okay.
So it's this population that's in Dr. Trin's practice. I mean, they've got a whole spectrum of age for hepatitis B patients, but there is a bias or a shift towards an older age population that are there, and they tend to be E negative. This E positive tends to be in the first 3 to 4 decades of life, and very unlikely after the 4th decade.
Nice. Okay.
So E antigen is not the same as genotype?
Genotype is a completely separate issue.
Okay.
In those first couple of slides, I was showing this, that branch point of A through J, and genotype has to do with a different part of the genome that's variable, but it's specific for regions, it's specific for certain clinical behavior also. And then core and pre-core mutations are other mutations in the virus that change how much E antigen the virus actually makes. So E antigen is specific to a phase of the disease. Everybody makes E antigen early. Most patients don't make E antigen late because of the change in the virus. But this really different. E antigen is a protein. Genotype, core and pre-core mutations have to do with the genetic material of the virus itself.
I see. Got it. I definitely had those confused, so thank you. And I think I might have confused Ale then, so I'm glad we're unconfusing ourselves. I have another question about platelet count. You mentioned, you had advised us previously and mentioned again here that platelets less than 150,000 can indicate, I think, the sort of NASH level that we're looking at, and less than 100,000 cirrhosis.
Less than 150 is fibrosis 3, which is bridging.
Okay. And
at less than 100 is fibrosis 4, which is cirrhosis.
Right. Okay, perfect. Perfect. Great. Thank you for clarifying that. Question about that fibrosis 4 cirrhosis. If we're looking at platelet counts less than 100,000 and it's indicating that, is that sort of a F4 cirrhosis, whether it's due to NASH or due to a virus like hepatitis B? Like it can be due to either or both, and we don't know the cause of their cirrhosis, but it's just an indicative of the, I guess, the phenotype of the cirrhosis. Maybe that's not the right word, or the phenotype of the liver.
The platelet count, the low platelet count relates to how big the spleen is. The spleen is big because of the level of scar tissue. It doesn't matter what caused the scar tissue.
Yeah.
Alcohol, fat, B, C, iron, autoimmune, anything that causes fibrosis increases back pressure into the spleen. As the spleen gets bigger, it tends to hide and consume platelets.
Okay. One more question for me. Can you explain a little bit why we're looking at bone health? We see DEXA scans in these hepatitis B studies. What's the correlation there?
So as people get older, they have bad bones. There's certain drugs in the hepatitis B world, like tenofovir, that has a bad effect on bone health. And people who have comorbidities such as diabetes and other metabolic disorders can have worse bone health. So we need to know bone health. It's really standard, and every patient with cirrhosis needs a DEXA scan. And then patients who are older with comorbidities should have DEXA scan, especially women, because menopause changes bone health dramatically.
Thank you.
Dr. Gish, can I ask about one more thing, please? The Stroop test. All of those questionnaires that we're seeing on the Novo NASH study, we had our first randomized patient and she was a little bit confused of why she had to do those questionnaires, mostly because she has to do them twice and then we get the score from the best one that she completed. And we were reading that it has to do with the liver. So we just want to know why the Stroop test is so important in this liver trials. And that way, whenever the patient asks us, like, why do I have to do this? This is like kindergarten stuff. We can better explain why we're doing it.
You're talking about Stroop, S-T-R-O-O-P?
Mm-hmm.
So the Stroop test, that's interesting. I didn't know that was part of the Novo Nordisk study. That's the Stroop test is typically done for people with encephalopathy with cirrhosis to check their cognitive abilities. And it's a very accurate test for change in cognition. But the Novo Nordisk excludes patients with cirrhosis, doesn't it?
Mm-hmm. Yeah.
So there's no reason to do a Stroop test in somebody who doesn't have cirrhosis. That's very strange. I mean, I have the Stroop.
Go ahead, I'm sorry.
I have the Stroop test on my iPhone. Looks like I need to reinstall it for some reason, but I don't, do they have an explanation on why they want
So
the Stroop test?
They're doing 2 clinical outcomes assessments throughout the study. They start at randomization and they go all 5 years so that the patient is participating. So it's the Stroop test, and then the other one is like a PSE, something, it's another what's it called, Ale?
PSE syndrome test.
Yeah,
Yes.
it's the Fez score. It's what that one is. That also has to do with encephalopathy, and it only relates to people with cirrhosis.
Yeah, we were thinking that like they started at randomization to get a baseline. So all the patients that enter the study are non-cirrhotic. And then over the course of their 5 years of participating on the trial, we're monitoring their health, and could they be developing cirrhosis over that time? So that's our best guess, but we didn't know if that was right.
That is very likely the correct explanation and the only explanation that I could even think about coming up with. So
how would we explain that to a patient though? You know, it feels a little scary to be like, we're going to monitor your cognition for your advancing liver disease, maybe.
I would turn it to something positive. So this is just going to tell you how smart you are, how great you're thinking. And we want to make sure that your brain keeps working great long term. You'll love this test because it's going to be, positive reinforcement for you. I would do something like that.
Okay.
Make it
Okay, thank you.
I have one more question.
Go ahead, please.
Yeah, I had a patient. They take the medication to treat the disease. When they use the medication, the DNA quantity is very low. That means the medication can reduce the DNA quantity, but when they stop the medication, the DNA quantity increase rapidly. So I would like to ask you when the patient can stop the medication, or they can use the medication for life.
So you're talking about in general. This is separate from the study, obviously. So when we treat hepatitis B with one of the first line therapies, entecavir, TDF or TAF, in that setting, we're telling the patient that they're going to be on those medications indefinitely. We don't use the word forever. We don't use the word lifelong because there's so many new drugs coming. That's not accurate. But indefinite means we will change or add a new treatment when they become available. That's usually the words that I use. But you are correct when you stop one of these first line therapies, the viral load rebounds within 4 to 12 weeks in most patients. But there are some patients who remain undetectable, 20% in some cases. And then there's some people who the viral level goes up, they get a flare of liver disease by ALT, and then they clear surface antigen. And those tend to be patients with low surface antigen levels, less than 100 or 200. That's why I'm using these 100 and 200 levels, obviously. So in general, we continue lifelong, or should say indefinite, not lifelong, and that we might stop treatment in subpopulations who can flare and clear infection.
Yeah. Yeah. Thank you.
Other questions from the team, anyone?
Well, we're almost to the top of the hour and we've only gone through 17 of 54 slides. So I'm thinking that we just stop here because this is what's relevant to this study. And we've hit on some other high points. I can share the rest of these slides with the team. And then you can decide if we want to have another deeper dive into this and go into the second part. I can move fairly fast through the rest, but it would not do it justice to try to cover that in 8 minutes. So I'd rather leave this at peace with you all.
I love it. And you just said Ollie's favorite phrase, to be at peace.
That's my quote, Dr. Gish.
Yeah. Maybe I could pose 2 more questions and we can decide whether those are good for another session or whether they relate or not at all. One question is, are there particular co-infections that we will likely see? I mean, we heard about the other forms of the other viral, like types of viral hepatitis. And some are co-infected, but we're not super familiar, but I'm just wondering how those may relate to what we will be seeing across the spectrum of trials at Dr. Trin's site and beyond.
You'll find hepatitis C in about 5% of the hepatitis B patients in the practice. And of course, that would exclude them from a clinical trial. But on the other hand, if they have hepatitis C, we can treat the C, cure the C, and then after that, they could become a candidate for research. Delta is going to be seen in 1 or 2% of the patients in this practice. I'm going to say I doubt that they've been checked for Delta in the practice, but I'm going to figure out how to protocolize that with Dr. Trin. But every B patient needs to have a hepatitis C, a Delta, and an HIV test in their chart. And we're hopefully over the next year or 2 can protocolize that and get that in everybody's record. Other infections we're not worried about, CMV, Epstein-Barr, herpes, those things really don't interact with hepatitis B, wouldn't influence clinical trials. And hepatitis A is never chronic, but we do check A in all the patients and then vaccinate them for hepatitis A if they're not immune.
A note on that, I've seen patients diagnosed with on the diagnosis codes, diagnosed with hepatitis B without Delta agent, but I never see the Delta on the labs.
I don't think they ordered it. I just think they put that in because Delta is infrequent in Vietnamese and Chinese patients. So they just said, oh, they can't have Delta because I don't see it, right? I've never seen it. It's just kind of funny.
Okay.
So it's it's a dilemma with that. So I'm really going to work with Hui to fix this E antigen, fix the Delta in these patients. It's very important.
Okay.
Okay, no more questions for me.
All right.
This was super helpful. Thank you so much.
And then just talk to the team and see if we want to go into the next part of this, which has to do with treatment and all the drugs we use. They're going to be doing a lot more hepatitis B trials, I think, in Dr. Trin's practice and hopefully in these other locations. So I think this is relevant, not just to today, but relevant to recruiting for future trials, deciding if we're going to do future trials. So I think a part 2 would be appropriate the next, 4 to 6 weeks if everybody agrees.
Yeah, I think it's super helpful to have a part 2.
Yes, agree. Yes, thank you.
All right, have a great weekend.
Thank you.
Thanks so much, Dr. Gish.